Thank you, everyone, for joining in today. My name's Joe Kalis. I'm an oncology clinical pharmacist with the UC Health System here in Colorado Springs, Colorado. And while I practice as a clinical generalist based in a physician office type settling for patient counseling and other support, I have seen a fair bit of sarcoma over recent years. And my colleague today, Dr. Richard Riedel, thought it'd be helpful to tie that in with Sarcoma Awareness Month. So if you could introduce yourself, sir, tell us a little bit about your background.
Sure. Thanks, Joe, for the introduction, and thanks everyone for joining. My name is Rich Riedel. I'm from the Duke Cancer Institute in Durham, North Carolina. I'm a board-certified medical oncologist with a clinical and research interest focused in soft tissue and bone sarcomas.
So I've got the perfect person here today then. To kick us off, Dr. Riedel, could you give us an overview of what sarcoma is and kind of what types there are, or what goes into it?
Yeah, happy to. I'll begin first, just again highlighting the fact that July is Sarcoma Awareness Month, as you mentioned. The term sarcoma actually refers not to one type of cancer, but a family of cancers that collectively are extremely uncommon. They represent about 1% of cancers in adults. They're actually more common in pediatric populations where they account for about 15% of all cancers. And they can occur anywhere in the body, most commonly in the extremities. That occurs in about half of the cases. Can also occur in the trunk and abdominal pelvic region. That's about 40%, and then 10% of the time in the head and neck. And these are cancers that arise from the connective tissues of the body, things like muscle, bone, fat, cartilage, nerves, blood vessels. And so they're challenging in part because of their rarity. They're challenging in part because of their heterogeneity. And often referred to as the forgotten cancer, in part because of limited financial funding. So it really is a challenging disease state.
Couldn't agree more. I remember, I think a recent article I'd read that it stated there were over 40 different types of sarcomas tying into that heterogeneity you mentioned. And I think you really hit the nail on the head there in that a lot of other cancers, so breast cancer, colon cancer, and others, there's really a greater public awareness of. But I think sarcoma being the quote forgotten cancer really summarizes things well. So you talked a bit there about how common sarcoma is and how often it presents, but especially with bones and soft tissues, what could be some warning signs of a sarcoma?
Well, certainly any sort of palpable mass that is growing and or painful is of potential concern. 99 out of 100 times, if someone has a lump that is small and painless, it may be something like a lipoma or other benign condition. And patients will often present to their primary care doctors, and they'll receive that diagnosis. And in the vast majority of cases, that's correct. But where we get concerned is if things are more than a golf ball size, more than the size of a golf ball, or certainly if they become painful or if they are rapidly growing. All of those are red flags in which individuals should consider seeking medical attention from a specialist.
Yeah, I think those signs really differentiate what could be a sarcoma, like you said, from things like lipoma, cyst, some other type of condition. And with sarcoma, again, as we called it, the forgotten cancer, do you feel like there's been a lack of the treatment advances, lack of research, or even FDA approvals for treatment of sarcoma?
Historically, all of those questions the answer would be yes. Between 1970 and 2012, we only had one FDA agent approved. But really, in the last 10 years, we've made some significant advances. And I think that's in part because we've started to think a little bit differently about our clinical trials. I'll just tell you, in the past, we used to lump all sarcoma subtypes together. We would try a particular therapy, and when it ended up being a negative study, we were left trying to delve into the data and understand or identify potential signals of activity among a heterogeneous group of enrolled patients. In the last 10 to 15 years, we've got smarter about our clinical trials, and we've actually now seen success in part because we are doing histology-specific trials. So in 2015, we had two agents approved, namely trabectedin and eribulin, specifically for lipo and leiomyosarcoma. We then had an agent approved called tazemetostat in epithelioid sarcoma, an agent called nab-sirolimus in an ultra-rare sarcoma known as PCOMA. And so we've really made some significant advances over the last couple of years, in part because of the way we design our clinical trials.
Yeah, and I think speaking to instead of lumping everything together and then trying a doxorubicin-based combination to see what helped or what didn't, focusing in on some of those unique pathologic subtypes, like what benefits each particular case of sarcoma the most. Is it this heterogeneity and honestly variety of different pathologies that makes sarcoma so hard to treat?
Absolutely. I think, one of the things that we've been challenged by is, unlike our other more common cancers, where, for example, immunotherapy clearly shows benefit, or there may be activating mutations in certain proteins for which therapies can serve as targeted therapies can be used. In sarcomas, the vast majority do not have identifying genetic changes that are considered actionable. There certainly are some, but they represent really a minority of cases. And so while there have been advances in a lot of other more common disease states, we continue to sort of fall behind our colleagues in that regard, which makes it challenging. We're using the same agents that we've been using for 50 years, namely doxorubicin and ifosfamide, as arguably the two most active agents that we have. We are starting to move the needle a little bit. And there are rare or ultra rare subtypes where targeted therapy has shown to be beneficial, but for the vast majority of sarcomas, we're still challenged.
Yeah, it's a often a challenging discussion for me to have with like the residents I'm helping mentor and teach because in other cancer types, I'll pick on colon cancer for example. It's almost like you can start in one place, there's a couple branches, and then it breaks off, and there's a defined treatment for each of them. We really don't have that type of roadmap or structure in sarcoma.
No, that's right. I mean, I think for the vast majority of patients, we still rely very heavily on cytotoxic chemotherapy. Regardless of the histologic subtype, in many cases, the initial first and or second line therapy is the same. But again, we are starting to be smarter about our trials. We are starting to begin to understand the underlying pathophysiology that drives the growth of tumors, and we are starting to see some examples of success in some of the subtypes that I mentioned.
'Cause I'd imagine with rare subtypes and smaller numbers of patients, really enrollment and accruing patients into a clinical trial has got to be very challenging.
It's challenging and certainly requires national and many times international efforts. Um, and so yes, I apologize for the background noise.
Oh,
It does
quite all right.
it does certainly pose a challenge, and so clinical trial enrollment really is critical in that regard.
Yeah, because like we can only rely on the data we've got and what's been accumulated, but if there's a paucity of data, it makes it that much harder to attempt to treat patients. Yeah, I think back several years to the development of olaratumab, talking here on clinical trials and how it was really hoped that that had identified a target that would work in several subtypes of sarcoma. And then as more data accrued and accumulated, unfortunately found that really wasn't the case. So I'm personally excited to see how the clinical trials have evolved and how the design has changed to really get us more, I think, reliable and actionable data. Go ahead, sir.
I was just going to say, no, you're absolutely right. Olaratumab was, we thought it was a home run. It led to FDA approval for about a year and a half. Based on the accelerated approval, our practice patterns changed overnight. And unfortunately, with the subsequent, what was supposed to be a confirmatory study, a phase 3 study, was just entirely negative, and we took a big step backwards, and we're back to doing what we had been doing for the 40 years prior. So yeah, that was a disappointment, and hopefully we've learned from that.
I certainly hope so as well. Like with the home run and being baseball season, I think back to the local pharmacy and therapeutics committee when I presented the drug, and I think I used the exact same terms. Like this is certainly an exciting development. Fortunately, didn't come to pass. But kind of keeping that perspective, are there any current or even upcoming clinical trials that you as a clinician and researcher are really excited about? Anything you've been keeping an eye on?
I think probably So there have been a couple. Certainly, we continue to make progress in GIST, or gastrointestinal stromal tumor.
Mhm.
We've had 2 additional agents approved in the last couple of years in avapritinib and ripretinib.
Mhm.
Um, there is, I think, a lot of enthusiasm regarding emerging cellular therapies, specifically in synovial sarcoma and myxoid round cell sarcoma, myxoid round cell liposarcoma, specifically looking at engineered T cell receptor products that target tumor antigens like MAGE-A4 or NY-ESO. Those clinical trials that have been done have showed very encouraging response rates in excess of 30%, 30 to 40%, which is far better than any of our more conventional cytotoxic chemotherapies. There's a lot of interest in dedifferentiated liposarcoma, looking at therapies targeting the MDM2 P53 axis, as well as the CDK4/6 pathway with specific inhibitors. There are studies in angiosarcoma that have shown promise using chemotherapy in combination, or using immunotherapy, for example, in combination with TKI-based approaches. And so I think there are a number of studies that are ongoing that have either recently been reported or will be reported that, again, are continuing to move the needle and make some progress in a disease state in desperate need of improvements.
And hearing some of those pathways, like recognizing CDK4 to 6 from current use in breast cancer, or even others like with specific T cell engagers, I'm thinking more like leukemia, myeloma, but being able to exploit some of those pathways, I think it really underscores for me the differences in growth and growth patterns from among these many, many different types of sarcomas.
Absolutely. No, absolutely.
Yeah, really not a one size fits all, as I like to tease my solid tumor colleagues. So having covered that ground, as we start to close, is there anything in particular that stands out about sarcomas, like maybe your top 1 or 2 things you would want our audience to leave with?
Well, I think certainly if there are any patients who are listening in or viewing this episode, I think it's critically important that if there is concern for a palpable mass and it's growing, and or certainly if it becomes painful, you've got to seek medical attention. And I think for anyone in whom there's a suspicion for a sarcoma, you are really best served by being seen, evaluated, and managed in centers with expertise. For perhaps community-based providers on the line who are listening, who may only see a few of these a year, please consider partnering with your academic colleagues at sarcoma centers. We are happy to partner with you in order to try to provide the best outcomes for our patients.
Yeah, and I'll second that. And having working currently in more of a community-based setting, we've got a very close working relationship with our sarcoma specialists up in Denver. And I'd like to hope that there's a similar outreach center or other programs that exist wherever our audience might be. Well, with that, Dr. Riedel, thank you so much for your time and expertise today. Really hope that our audience will benefit from that.
Thanks for having me.